welcome everybody who might be joining us for the third SBU on your bowel management program. It's all in the routine. And so let's go ahead and get started because we have a really full program, lots of great information from our presenters. Before we start, wanted to tell you a little bit about what SBU is if you have not joined us before. It's a series of webinars that are designed to be conversational presentations by experts in whatever subject it is we're talking about. And those are healthcare professionals and adults with spina bifida who are real-life experts on the subject. The goal is to present practical information as well as tips and suggestions. And the topics that have been selected are based on surveys of adults with spina bifida who've shared their concerns about day-to-day life with spina bifida. And before we get started, just a couple of things about this topic. You know, a lot of times we tend to avoid talking about bowel management. In a way, it's been sort of described as being a little bit of a taboo subject. But the reality is that in recent surveys of adults with spina bifida, we know that bowel management is a top concern. It's really a quality of life issue. And then also too, before we get started on the presentation, on the topics that we're going to cover today, just wanted to be sure that you understand that this information is not, we're not providing like individual medical advice for any person. But if you have any questions about your particular situation, please do email me, Juanita Panliner. My contact information has been in the registration information that you provided, and it will also be again at the end of this webinar. So today we're going to discuss the medical and social reasons for keeping a bowel management routine. We're going to talk about how hygiene plays an important role in social interactions. We're going to talk about what makes a bowel management routine successful. What are some commonly used routines? And what are some suggestions to establish a routine, which sometimes can be tough as you become an adult. Also, another important piece of information is how do you talk about your routine with other people, and who can be some sources of support. And so now we've got our presenters, and I would love to have each of them introduce themselves.
So my name is Fiona Paul. I'm a nurse practitioner at Boston Children's Hospital. I am the gastroenterology provider in our spina bifida center, where I provide the GI care for pediatric and adult patients. I also coordinate our motility and colorectal program here at Boston Children's. And I have extensive both research and clinical practice knowledge in the care of neurogenic bowel.
Great, thank you, Fiona. And Adam, would you like to introduce yourself?
My name is Adam Guerrero, 27 years old. I was born with spina bifida. I'm a motivational speaker. I have 8 years experience as a public speaker. Recently got into a weight loss journey. It's been going on for about 1.5 years now. That's part of my routine. I'll get into that later. And I'm hoping to encourage you guys to figure out the best bowel management care that works for you.
Great, thank you, Adam, and we look forward to hearing about that. And Amy, would you like to introduce yourself, please?
I am Amy Richards. I live in Massachusetts. I'm 30 years old and I have spina bifida. I am a trained special ed teacher and reading specialist, and I work full-time as a tutor in Massachusetts, and I am involved on a couple advisory boards with the National Spina Bifida Association, and I'm also on the board of directors with the Spina Bifida Association of Greater New England.
Great, well, thank you, Amy. So Fiona, let's start with the more technical aspects about bowel management, or how the bowels work.
So I think it's really important to have at least a foundation knowledge in this area, just so that we can understand when we're talking more about bowel plans, what may work and what might not work. So if you think about the GI tract, we absorb all of our nutrients in the small intestine, and the small intestine also produces liters of fluid a day. That fluid and the waste products from what we don't absorb goes into the colon, or the large intestine. And the colon has two functions, really. One is to draw water back out from the water that's put into it so that we don't get dehydrated. If you didn't have a colon, you would have diarrhea all the time. And the other one is to just move the waste down to the rectum. Once it travels around the colon, there's this last bit of the colon called the sigmoid colon, which is really kind of a shelf. Some people refer to that as the bladder of the bowel, because stool tends to really accumulate there before it goes into the rectum. That sigmoid colon then gives that last squeeze of the stool, and then it fills the rectum. Once it fills the rectum, it causes a stretch in the rectum, and that stretch should ideally send several messages to the brain. So one thing it sends is just that sensation that I need to have a bowel movement. The other thing it does is it works on our sphincter muscles. So the first sphincter, that internal anal sphincter, has what we call an involuntary response, which means we don't have conscious control over it. So once we have the stretch of the rectum, that internal anal sphincter muscle, if working properly, should just relax open and allow the stool to drop down. The stool then drops down where it meets the external sphincter muscle. And ideally, we have control over that external one, that we have voluntary control over. And so if now is a good time to have a bowel movement, we can open it and expel the stool. If it's not a good time, hopefully we can close it down. The stool then goes back up. It passes back through that internal anal sphincter, and it should close down nicely, and you should lose the sensation for a little bit.
Okay. And thank you. And now, can you tell us what neurogenic bowel syndrome is? Neurogenic bowel dysfunction.
Sure. So once you get an idea of kind of how the colon and the rectum work, you can see that there's lots of places where things can happen. So the first thing that we see is just the way that the stool moves through the colon itself, and we call that colonic transit. So that can kind of run the whole spectrum. It can be too slow, it can be too fast, or it can actually move through at a normal speed. So if we again kind of remember what the colon's jobs are, one was to draw the water back out of the stool so that we don't get dehydrated. So it goes to figure that if the stool is sitting in the colon for a long period of time, that it's going to be harder. Whereas if it goes through faster, it's going to be softer. Once it goes through, it ends up in that last bit where we said that sigmoid colon. And that oftentimes we see in neurogenic bowel can become weakened. A lot of times it's more the people who have very slow transit or constipation. The stool tends to hang out in there a lot and build up, and that area gets stretched out. And if you think of it like a balloon that gets maybe hyper stretched and then loses some of its elasticity, and so it can't really give as good of a squeeze at the end. Then once it does end up, the stool does end up in the rectum, the response is abnormal usually. So what the internal anal sphincter that relaxes open when we have that stretch, in folks with neurogenic bowel, it relaxes open with far less pressure, so it does not take much to open it up, and it does not close down as quickly, so it stays open for a while. And the sensation is diminished. So some people have, different sensation or slight sensation. Some people have no sensation at all. And then the control of that external sphincter, that the one that there's voluntary control over, can be weak or absent completely. So we kind of see with that, then it's a little counterintuitive, but what we try to end up doing is making people a little bit more on the constipated side. We want to make sure that the stool has some texture, because if it's not causing that stretch in the rectum, then there's going to be you know, we need that in order to have any kind of signal that if there is any sensation, that the stool is there, and any ability to hold, we need the stool to have some consistency to hold it. So we want you to be a little bit on the more backed up side, but then have a plan for emptying on a regular basis.
Okay, thank you. And so why is it medically important to keep a bowel management routine?
Sure. You know, our overall goal is to really attain social continence. And there's a number of reasons why we want to see that happen. Some are obviously, you know, pretty obvious, but then for medical reasons, if people are very constipated, this can put a lot of pressure on the bladder. And my colleagues in urology are always, you know, saying to me that you know, they need patients to be free of as much stool as they can, so that the bladder isn't being impinged. It can cause urinary retention. It can cause some leaking. It can predispose you to urinary tract infections. Certainly, if you're having a lot of incontinence and leaking, particularly in females, this can be a problem for urinary tract infections. And then also preserving the function of the colon, right? Like we said, that sigmoid colon that can get really stretched out if there's a lot of stool sitting in there. We want the colon moving on a regular basis. We want people to be emptying on a regular basis. The skin health of your perineal area we can get breakdown and rashes. And then the impact on mental health can be profound. The quality of life. There's been a number of studies, my own studies and other studies in the literature, looking at the impact of quality of life on that constipation and incontinence has. And certainly we see an increase in things like anxiety and depression with these symptoms.
Great, thank you very much for presenting that, Fiona. And now, also very important is the social impact, or the impact that a bowel management routine might have on you socially. And so to get us started on that subject, Adam, please go ahead.
So the first thing, you know, first bullet point says, you know, you want to avoid smelling bad. You want to avoid an odor. You know, I know for me growing up, I had a hard time keeping friends. And, you know, it would be, you know, hurtful to find out like, oh, I didn't have that many friends because of a bad smell. And I've kind of had the same situation come up recently. And I have a pretty good bowel management routine, but I'm doing my best to get a hold of that. Another reason is you don't want to have frequent accidents while you're out with your friends and family. Say you're at a barbecue and an accident happens, well, you have to go excuse yourself. Maybe it's so bad you have to clean up, or maybe you eventually have to leave. And if that keeps happening, you're not really going to make it out anywhere. You're going to feel like, oh, no one wants to invite me. It's always a burden. And kind of going back to what Fiona had said about the mental health, kicks in depression and other problems.
Okay, yeah, thank you. And Amy, then the same question goes to you. From your perspective, why is it important to keep a bowel management routine in terms of the social life?
Right. So having a routine that helps you stay more regular and stay cleaner, like Adam had talked about, it really just helps you stay focused on whatever other goals you have in your life. So whatever you're trying to achieve at the time, whether you're trying to finish school, you have a job, or you're trying to apply for jobs, whatever it is, you can focus more on that rather than focusing on kind of managing the symptoms of not having a successful routine. And Adam touched on this as well, you know, when you're scared that or nervous about having accidents, you can, whether it's intentional or not, you can isolate yourself. So, you know, it might be that, well, I'm not feeling well today, so I can't go do these plans that I had. Or it can be, you know, maybe you would avoid making any plans socially because for fear that you're going to have an accident, and so that can be damaging. And then, you know, it really is going to help you stay on time. You're going to avoid any, as much as you can, you know, you'll avoid embarrassing situations, late to things, missing things. And then lastly, it's really important to your self-confidence. So we'll touch on this more as well, but talking about the mental health side, and also just your overall comfort, whether it's just in social situations or if it's during intimate situations as well.
Okay, thank you, Amy. And now in terms of hygiene, Amy, maybe you can get us started on how hygiene is vital to personal interactions.
Sure. So, when we're worried about an odor, or we're worried about if, well, I just had an accident and I can't make it to the bathroom right away, or I need to go make it to the bathroom, are people going to be able to tell? There's that just like constant inner dialogue that happens. And that can be damaging if that's going to be something that happens, for a long period of time. It can really affect your self-confidence in a lot of ways. And then, other people in your family, your significant others, your spouses, they'll see this, and they become concerned that the person that they're caring for or they care for is embarrassed about this, or, maybe they're not feeling as healthy as they could. And it can take a toll on relationships as well.
Thank you, Amy. Excuse me, and Adam, would you like to tell us from your perspective, how is hygiene vital to personal interactions?
Well, as I mentioned earlier, you want to avoid having this odor. You want to do your best to be prepared for accidents if they happen. I know for me personally, I always have emergency supplies with me, an extra pair of pants or shorts, some cleaning supplies, extra catheters, other things like that. Just because it's come up in my life, and you never know when it will happen. You could have the best routine, and sometimes it just happens. I know not too long ago I was feeling sick for a while and kind of off of my routine for a bit just because it was a stomach flu. I was finally feeling better, decided to go to the gym to exercise, and halfway through my workout, stomach started hurting and I had to rush to the restroom. Fortunately, I had the cleaning supplies and I was able to just clean up the best I could, get home, and finish up without any embarrassment or any kind of problems.
Yeah, so it really just teaches you just have to try to be as prepared as possible. And so now Adam, how have you adapted your routine, your bowel management routine, to fit your needs and your schedule?
When I was younger, my doctors always pushed for a certain bowel management routine. They always told me, this is what you have to do. This is going to be the way it works. And I tried, and it didn't work for me. As I got older, I got more into exercising here and there. And I noticed that with my exercising, and depending on what I eat, that kind of helps me to stay regular. I work on my core quite a bit. I do sit-ups, push-ups, leg raises, and that helps me to stay regular and keeping track of, like, okay, am I drinking enough water? Because sometimes if I'm not, I may get constipated. So drinking enough of that, not eating too much of this, eating too little of that. And that's what helps me with my routine.
Okay, great. Well, thank you, Adam. And now, Amy, same question for you.
Sorry, I just got off the screen for a second.
It happens.
So I basically have tried a couple different things throughout my adult life so far. And I think growing up, things were a little bit similar to me, for me, than as Adam's situation, where my parents actually were the ones who said, this is what you need to do. We have to do it, every other night. This is your routine, and there's no leeway. And I think that kind of made it a little bit difficult for me growing up. And when I started to live on my own, and social events are coming up more often, where, I had a hard time figuring out how to implement my own routine based on my life. So, and I'm honestly still really working on trying to figure it out. It's not something that I have perfected in any way. And like I said, things will come up and throw you off of your schedule, but basically what you're going to try to do is adapt what you've been given by your doctors, by your medical providers, and figuring out what works for you. And when you do get off track, getting back into it will maybe take some time, but you will eventually get back to a place where you are feeling better again. And I think, my whole kind of takeaway from my experience so far and my suggestions for, others is really to kind of take control over your own routine and do what works for you personally, because otherwise you're not going to stick to a routine if you're not doing it for you, and if you're doing it for other reasons.
Okay, yeah, good advice. Thank you, Amy. And now, for you also, Amy, what are some common challenges for you to keep a routine?
So there's a lot, for sure. I was kind of listing them all out, and there were a lot of things that come up. The first one I always think about is, you can't always plan ahead. You can plan ahead the best you can, and then, accidents are going to happen, and they might happen at the worst times, and it's all just kind of how you deal with it in the moment there. But, when you do plan ahead, you're thinking about, when am I going to have access to a restroom, to a bathroom? Where, can I clean up? Am I going to have access to enough space for this, enough time for this? And other challenges will include too, your own reaction, your body's reaction to whatever routine you have. Growing up, I did or not growing up, I guess it was in high school and college, I used the ACE. I had that procedure done when I was a junior in high school, and the purpose of it was so that I could go away and live on my own at college. And it did what it needed to do, but it didn't always. So sometimes it would work, and other times, I would go through the motions, and I wouldn't actually be able to use the bathroom for several hours, and it was really difficult. So that can definitely cause some problems. And then, as an adult, you have your work responsibilities, you have your work schedule, your personal schedule, and you really just have to prioritize, I guess, and you really have to work around your responsibilities as best you can, but then also putting your health first. And then what happens too, at least for me, is if I'm feeling, I do have depression and anxiety. So if I'm having a particularly hard time with that, sometimes that'll lead me to not want to take care of myself as much. And then it can kind of be this vicious cycle where, the worse I'm feeling in my gut, the worse I'm going to be feeling mentally. And it can be a challenging thing to work out of.
Well, thank you. Thank you very much also for being candid about, what's very real for, I'm sure, a lot of people as well. So Adam, for you, what are some common challenges to keeping a routine?
For me, it's social situations. As Amy had said, you don't know when an accident is going to happen. Sometimes happen at the worst times. I've had moments to where I've had to excuse myself, where I'm out with friends. Another thing is living arrangements. I've recently moved in with a roommate about a year ago, and we didn't really know each other that well until I started living with him. And so letting him know, hey, sometimes this situation happens. I have these kind of supplies. I'm going to need these arranged in the bathroom so I can get to them, so on and so forth. Also, like Amy said, your mental health status. For me personally, if I have a bad day, my stomach is messed up, and I seem to be off track, that kind of gets rid of my motivation, and I feel like I don't want to work out and stay healthy anymore. But it's just, I have to remind myself, this just happens. This is a little bump in the road. It's not a complete block. I can get over this. And once you get over that, you can reestablish your routine and get back into it. And next thing you know, you start feeling better about yourself. Another thing that helps me is a support system. Certain people that know what is going on, like my parents, close friends. If they've invited me to something, I can just like, hey, this kind of happened. I won't be able to make it. and they can be understanding about it. You know, it happens from time to time. And I can't stress this enough. Having a routine won't eliminate accidents, but it helps to reduce the frequency of the accidents. So understand that it can go from having accidents weekly to maybe once a month. You know, it's the lesser of two evils, so to say. It gets better over time, and you got to figure out what works best for you.
Okay. Thank you, Adam. So Fiona, I'd like to go back to you now so you can tell us what are some of the elements of a successful bowel management routine.
Sure. I think before I say that, I just wanted to touch on something that Amy said earlier about, you know, the mental health part and the bowel care and how they both play off of each other. And we know that there's such a huge mind-gut interaction that you're certainly not alone with this, that when you're feeling, you know, depressed or anxious about, you know, anything, that has an impact on the bowel, and then vice versa. There's so much communication there that it's that you're certainly not alone in those feelings. But moving along, I just didn't want to forget to say that. Moving along, the elements of a successful bowel routine. So I think when I'm sitting down with a family to try, or a patient to try to develop a bowel management program, the most important part, and I think both Adam and Amy have really touched on this, is making sure that patient preference and lifestyle is taken into consideration. Because I could sit here and say, well, you know what, I know if we did this plan X, and, you know, you did an enema program every night, you would be clean and you wouldn't have accidents, and this is the way we should do it. And if that's not, whatever the plan is not going to work for you, then it's moot, right? If you're not going to continue to do it, then it's not a good plan. I liken it to myself. You know, if I was to go to the gym and I wanted to work out with a trainer to get in better shape, and the trainer said, well, you know what, you need to be exercising. This plan I've got for you, it's going to work great. If you do it 1 hour every day, you're going to be in perfect shape. Well, knowing myself, I don't have that, nor do I want to dedicate necessarily 1 hour a day to the gym. And so that plan would not be for me. So unless I speak up to that trainer and say, you know what, that's not going to work for me, we need to have something that works for both of us. And so the same thing goes with this, right? If you need to work with the clinician and say that, you know, that's not going to fit my lifestyle. If, you know, I have some patients who say, absolutely, I will not do anything into the rectum. And I have to respect that. Some people, you know, are interested in, I know Amy talked about the ACE procedure. So some people are interested, and I'll talk a little bit more about that in a little bit, for, you know, the surgical intervention. Some people absolutely not. Some people want to try oral medication. Some people are totally adamant against oral medication. So it really is taking into consideration the preference and their lifestyle. I like to try also to kind of do a step-up approach. So starting with the least invasive to more time-consuming and invasive procedures, and see where we can, you know, where we meet a nice sweet spot. Certainly I need to keep the goals developmentally appropriate, right? And I think Amy kind of touched on this as she had one plan when she was a child and, you know, under her parents' care, and then they transitioned to another plan for when she was going off to college and being independent. And now that she's living on her own, she's on even a different plan. And so the plan, what might work for you when you're 8 years old, may not work for you when you're 30 years old. And certainly when I see a patient, if I'm seeing a 2-year-old in the office, because I do work at Children's, you know, at that point, the goals are very different. It's still very socially acceptable to be in diapers, as opposed to when I'm seeing somebody in high school or in college or, you know, working, the goals and their life and their development is certainly very different. Another thing that's important is individual abilities. So what is the level of mobility? Is this something that you're going to be able to do yourself? Because I think when I am trying to manage bowel routines throughout the lifespan, initially I just want patients kind of going regularly. Then certainly I want the achievement of social continence. But then the final thing that's so important is independence. And for some people, it's not going to be total independence. If there's somebody with very limited mobility, they may certainly need some help from a caregiver. But the least amount of intervention that we can have from somebody, and if there is a caregiver, what are the things that they're comfortable doing and able to do? And then we need to modify it. And I think both Amy and Adam kind of talked about this. So I try to have a plan for every day or, normal, but then we have to have backup plans. What are our emergency plans for when things change? Illness is a big one. What do you do if you have a UTI and you're on antibiotics and the stools are looser? What do you do if you have a stomach bug? I work in pediatrics, so I have kids who they say, well, on my days that I'm in gym, I'm more active. And so those are the times when I tend to have accidents. So we have a separate plan for regular days and gym days. What happens with travel? So all these kind of different things, we need to take those into consideration.
Great, thank you, Fiona. And now can you tell us what are some methods for bowel management?
Sure, and again, like I said in the earlier slide, I wanted to try to start with the least invasive and the most minimal interventions and kind of step up. So first starting with things that Adam really has highlighted, these lifestyle interventions, if they can work. Certainly diet's a big one. Some people have trigger foods. They know that if they eat them, they're going to really clean them out, which can be helpful if they need to be cleaned out, but not so helpful if they're eating them on a regular basis and they're causing diarrhea. Timed sitting sometimes is helpful. I have some people who just, every time they cath, they try to push and see if they have stool. Bowel movement. The colon wakes up when we first wake up in the morning. So oftentimes people are morning poopers after you eat a meal or with exercise, like Adam was talking about the exercise. So those kind of techniques that we try, that with proper body mechanics of how to sit, to try those interventions first. Then there's oral medications that we can try. They run the whole gamut. So some of them, like Colace, just lubricates the stool, so it makes it a little bit slipperier, easier to get out. There's medications that draw water back into the colon. We call those osmotic laxatives. Those are like your Miralax and milk of magnesia. I tend to stay away, particularly from Miralax, which I think is kind of one of those medications that's like a feast or famine. In order to give enough to go, oftentimes it causes very loose blowout stools. When if you think back to our earlier slide about the way that we can control and hold the stool and sense the stool, we don't want the stool to be too loose because that may really cause more accidents. Then there's the stimulant laxatives, things like Senna, X-Lax, or Bisacodyl, which is Ducalax. Those medications help the colon to contract, so they help the stool to move down. They don't necessarily make the stool softer, but just getting the stool out faster will make the stool softer because, as we said, the longer the stool sits in the colon, the harder it's going to be. And then there's more newer generation medications that are more motility drugs that help really the whole GI tract to move things through. Medications can be helpful sometimes to add, but often they're unpredictable, right? You take them, they need to break down, get absorbed, and then work. And so it's hard to know how long, when they're going to kick in. And if they kick in when you're sitting in class, or you're sitting at your job, or you're sitting on a date, that can be an uncomfortable situation. So while I use some medications, we don't always use a lot of laxatives. Then there's rectal interventions. The nice thing about those is they work fairly predictably. So typically you give something in the rectum and it will work within about 15 minutes. So that is a lot nicer than giving something in, by mouth that we don't know when it's going to work. We can start with things as simple as just suppositories or little bulbs of liquid glycerin or enemas. The problem sometimes, though, is just given the problems with the sphincter muscles that we said before, where that internal anal sphincter muscle takes very little pressure to open wide up and it doesn't close down easily. And then there may be a lack of control of that external sphincter muscle that oftentimes when we put these kind of medications in, we find they just come right back out. And things like suppositories don't even get absorbed before they're coming right back out again. So then we start to think about some of the enemas that are specifically designed for neurogenic bowel. So things like the cone enema, which is basically an enema and has a tubing with a cone at the end. The cone is, about yay big. You don't have to stick it in all the way, but it goes in and causes a little seal so that it keeps the fluid in until you're ready to empty. You have to hold it in, though. It's not going to stay in place, despite the nice little graphic that comes on the teaching material of people magically sitting in the toilet with the cone somehow miraculously staying in their bottom. That doesn't work. So you have to hold it in. So it is cumbersome. Then there's things like the continence enema catheter, which is a catheter that has a balloon at the end. Again, somewhat cumbersome. The newer things that we have now, which we've been using for the past few years, are transanal irrigations. And a lot of people are quite successful with these because they help a lot of people also achieve independence as well as continence. So this is things like Parastine. There are newer ones out there as well, but Parastine is one that I've used the most. And it's a catheter that, again, has a balloon that inflates at the end and goes to an enema bag with a pump. So you manually are pumping and the water goes in. So it's more of an irrigation. It's cleaning out not just that rectum, which when you're giving a traditional enema, you're really just filling up the rectum, letting that empty and hoping that more will follow. With the transanal irrigation, you are shooting fluid up into that last bit of the colon. So it's really collecting and moving down more stool. I found that it works a lot quicker than traditional enemas, and we usually get more stool out. And the more you can get out, if you can clean out that whole sigmoid colon, then the less likely you are to have an accident. Then we start to talk about surgical procedures such as the ACE, which Amy was talking about, and ACE just stands for antegrade continence enemas. So what we're talking about here is making some sort of a surgical conduit so that we can give enemas from the top down, right? So traditional enemas you're putting up into the rectum, even anal irrigations you're putting up through the rectum. This, you're making some sort of a port so that you can give it from the top of the colon down. There's an appendicostomy tube, which we use the appendix. The surgeon will take the appendix and pull it up to the skin level. Oftentimes they'll use the belly button or right near the belly button. They'll make a one-way port so that you can intubate it with a catheter and give the enema that way. Or you can make what we call a neo-appendix somewhere in the colon if you don't have an appendix, or some people have used their appendix for Mitrofanoff to catheterize for urine. So they can make another kind of catheterizable stoma on the colon, or sometimes we'll put in a feeding tube device. So you have a small button device in the colon to where you can intubate and give those enemas that way. Then with folks who have been, just resistant to everything, particularly for some of our patients with severe mobility issues or cognitive impairment, and who've really failed everything, then we start to think about a diverting ostomy, where we kind of take the colon out of play and just collect with a colostomy or an ileostomy. But we don't really do those very often.
Okay. Well, thank you, Fiona. That was really thorough. Thank you very much. And now, so Adam, now Adam's gonna tell us about the how important communication is and how you can communicate to others about your routine. And excuse me, and so Adam, how and when do you talk about your routine?
When I was younger, it wasn't really that easy for me to talk about. The only ones who knew about my situation were my family, and even then, it just was down to my parents. Not even my siblings knew all the details of things. But over time, I've gotten close with friends, and I've learned to develop like a go-to phrase. And they don't know exactly everything, but they understand that when I say, hey, excuse me for a minute, or I need you to go grab my bag for me. For example, say I'm stuck in the restroom for something and my bag with my supplies is on my wheelchair. I can text them, hey, grab my bag and just kind of toss it in here for me. They don't ask some questions, they know I need it, and just kind of give it to me. And it's important to do this because you can't do this all on your own. You're going to need some help at some point. And I learned that over time. And it's really helped me in situations to be less embarrassing. And if you don't really have anyone to be that intimate with, learn to speak with someone, confide in someone so they can know of some situations and help you in some way. Like I said, they don't need to know all the details of like, oh, I need a clean pair of pants. They're just like, no, I need these supplies. Just bring them to me. No questions asked. And maybe there's some times where you have to advocate for yourself. There's been situations where I've gone out to different little occasions and the bathroom isn't, let's say, handicap accessible. And so I'd have to speak up to a manager or someone in charge and say, hey, can you point me in the direction of a bathroom that's maybe bigger? Maybe it's an employees only bathroom or something. And that's gotten me out of, some situations, avoiding accidents, avoiding embarrassing moments. You also want to know who needs to know, what they need to know, and how much they need to know. My roommate, for example, he knows I get supplies monthly. And I just tell him, hey, just throw those in my room. I take care of where I need to put them and so on. He doesn't know my routine of how often I need to go, just that these are my supplies. This is what it is when it comes to the door every month, and just put it somewhere where I can reach it.
Well, there you go. Thank you and I'm sure that, when like you said, like this is something that you kind of worked through over time, figuring out how to talk about this. So thank you for sharing that with us, Adam. And now, Amy, would you like to tell us about who you go to when you want to, either have support or have these conversations?
Yeah, so definitely when you're if it's a bigger issue or you're trying to find a new routine or the one that you have isn't working, your nurse or your primary care provider, your gastroenterologist, whoever it is that you go to for your medical needs, that really is going to be your biggest you're the most important person to go to because they're the ones that are going to help you get what you need and stay healthy. But on a daily basis, it's really those trusted friends that you have. I was lucky enough to grow up with a group of friends that I was really close with, and I was able to tell them, at least most things, at least most details growing up. And it's one of those things that some people you want to share it with and some people you don't, and whatever you choose to do is okay. It's totally your choice. The people that you have in your life who also have spina bifida are obviously going to be great people for you to confide in, but it's not one of those things where they have to have it to understand or to at least be someone to talk to. So there really can be anybody that you could feel comfortable with. And I don't know, there's people who you have in your life, like for me, most of the times now, it's my husband, and, I'll tell him, I'm having a really bad day, and he usually knows what that means, and, it's really helpful. And when you get into those hard days, it can be hard to kind of remind yourself why you're doing it, or like, why do I even try? I'm just going to have more accidents, because they do happen whether or not you have a good routine. But having those support systems in place is really important, especially when things, when you're feeling that way. So as long as you have, at least you have someone, whoever it is, someone that you feel like you can go to or talk to, that's going to be really important, and it's going to help you stay on track and just do your best.
Great, thank you, Amy. And now, Fiona, this is an opportunity for you to give us a little bit more detail about this communication aspect that we were talking about, particularly with with healthcare providers.
Yeah, I mean, I think that having a good patient-provider relationship is really important, and you need to find somebody that you're comfortable with and who listens to you, right? I think Adam had talked earlier about when he was young, having somebody who said, this is the plan, this is what you need to follow, and this is the way it is. And that's not going to work. So, and particularly as an adult, maybe we have a little bit of that when we're children. Amy, you said your parents were like, this is the way it's going to be. And I understand that to some degree, but as certainly as we become adults, you're the boss of your body, you're in charge of everything. So you need to find somebody that you feel comfortable who you can work with. I think it's also really important that you bring up your bowel management, because it may not be the first thing that your provider will ask you about. We tend to kind of prioritize as clinicians things like, your heart, your brain, all these things that are very important, obviously. But so in the scheme of things, I think bowel management gets kind of pushed aside. And it's also one of those things that not a lot of people really feel comfortable talking about. So, but it's very important to talk about it. And I know that, not everybody has a GI specialist, and not just a GI specialist, but a GI specialist who's well versed in neurogenic bowel dysfunction and the care of it. So, I mean, that would be certainly ideal. But if you don't have that, finding that provider who is willing to kind of learn with you and explore with you and reach out and try to help you to develop a good plan is really important.
Thank you, Fiona.
Welcome.
And now just some closing thoughts before we have a little bit of time for some questions. And Judy, we wanted to introduce also Judy Thibodeau, who is the Spina Bifida Association's Director of Research and Services, and wanted to know if you had some thoughts that you wanted to share as well.
Thanks, Juanita. I want to let everybody know that the Spina Bifida Association knows this is one of the most, if not the most significant issue that faces people with spina bifida. We know it affects employment, it affects relationships, it affects social participation. We are working right now with the NIH to find ways to explore research opportunities to learn more about the neurogenic bowel in spina bifida, because I think Fiona has given me that hint too, that it's different in people with spina bifida than for instance, for people with the spinal cord injured. So we are digging deep to find opportunities to learn more. It'll become one of our advocacy points for Teal on the Hill next year with Congress. And we are right now begun to develop a Spina Bifida Association bowel management protocol, which is just like Fiona said, from the least invasive to the most invasive, but to encourage clinics to begin with infants to address bowel management. And we appreciate so much the comments from Fiona and Adam and Amy. And thank you, Juanita, for the chance to comment.
Oh, thank you so much, Judy, for for sharing that. And just some of the things that Judy mentioned. If you are curious about keeping up with what the association is doing, please just visit our Spina Bifida Association page on Facebook, and also you can always take a look at our website at spinabifidaassociation.org. But and I think so, but there were some closing thoughts here as well that were really important. And Fiona, I wanted to give you a chance to also share these.
Sure. So I think, certainly, again, like I can't say enough, just don't be afraid to speak up. Talk to somebody, talk to your provider about getting a better plan if things aren't going well. And remembering that one size does not fit all. It's not a cookie cutter thing. What might work for Adam wouldn't necessarily work for Amy, wouldn't work, might work for somebody else. So that you need to get a plan that works for you, that fits your lifestyle, that you can do, that fits into your time budget, but also that works. And if it's not working, don't be afraid to then go back to that provider and say, listen, this is not working. I'm having a lot of accidents with this. And if they say, well, this is what we do, then I wouldn't hesitate to maybe find somebody who can help you more effectively than that.
Okay, thank you so much. And one thing that I failed to say at the very beginning is that we are able to get questions. So if you questions from you. So if you're able to go into, I believe it's the little chat function on your screens, you can submit questions to us that way. But before we move on to that, there was just one more thing that we wanted to show you. Here's some additional information, some additional materials that you can take a look at later on in your own time. This information will also be posted on our website in the archives for SBU. The first one is a booklet. It's a actual print material, and you can just send me an email if you would like a copy of that. And then the other resources are pages on Facebook, support groups on Facebook that some people have used. And actually, I skipped over the Bowel Management for Spina Bifida. It's a website, so if you just click on that link, it'll take you there. And then there's also information on one of the systems that Fiona was discussing, the transanal irrigation systems. We also have our guidelines for the care of people with Spina Bifida. And there are guidelines for people of all ages, but since we're focusing on adults, I've only shared the link for adults. And then also too, Adam was kind enough to share with us a couple of videos of the routine, his exercise routines, his workout, his fitness routines that have been successful for him in terms of his bowel management routine. And actually I'm getting some questions and I have to check and see what they are. Okay, so I have one question that says that, Fiona, you mentioned something newer than Peristeen. And what is that? Do you know? Oh, and you're muted.
Sorry, my bad.
Okay.
Yeah, so this was the one, actually, you had sent me the link to it. It's very similar to Peristeen. It's basically the same thing. It's just a different manufacturer who's now making it. It's the you're the one who sent me the link.
Oh, the WellSpect?
WellSpect, yeah. And it's definitely the same kind of a system. It just has 2 pumps as opposed to 1 pump. I think they just obviously tried to make it look a little bit different from Peristeen since it's a different manufacturer, but it's for all purposes that it's very much the same.
Okay, cool, thank you. We also have another question. It's like a twofold question. This is for our panelists. What dietary restrictions do you follow? What restrictions don't work, and which are the foods that trigger diarrhea for you? So maybe, I don't know, let's start with Adam.
For me, any spicy foods kind of cause me to, have diarrhea. If I'm desperate enough, maybe I'll eat something spicy and just like clear me out for a day. But, it's not something I would continue eating. I try to stay away from eating a whole lot of cheese, even though I do like it, and that usually will get me constipated. Drinking a lot of water, plenty of fruits and vegetables help me to stay regular. One thing that's helped me with my weight management was a low-carb diet, so not many breads, potatoes, things like that.
Okay, thank you, Adam. And Amy, would you like to share some of your restrictions or what you like to eat?
So, yeah, well, the problem is I like to eat everything, so it's a struggle. But I guess along the same lines as Adam, you know, spicy foods have always really bothered my stomach more than others. Really greasy foods, for sure. And I have also been trying to do a low carb diet. And I have noticed that when I do that and I cut out a lot of carbs, especially like the complex carbohydrates, so like breads and processed foods and other things, you know, and then I go back to eating them after, then that really upsets my stomach. So a lot of times, you know, when you make it like a drastic change to your diet, it'll really upset things. But it's, but once I get into like a routine with it, it tends to get a little bit better. Cheeses will sometimes go both ways. It depends on the type of cheese, hard cheese, soft cheese. And I can't really think of anything else corn will upset my stomach as well. So I've always had like a limit to how much of these foods I would eat, you know, try to stay healthy, but also trying to stay regular.
Cool. And there was also a question about, in what way does doing exercise help with keeping a routine? And I will watch on the video screen who wants to take that question.
I'll start, but I know this is Adam's thing as well. But I wanted to say one thing about the diet stuff too, because it is very individualized, right? That everybody might have certain trigger foods that make their stool looser or more constipated. But certainly there's, you know, some foods that we see that are binding, things like, you know, bananas, rice, cheese, that kind of stuff. And some foods that might make you go more, we usually say like the pea fruits, prunes, peaches, those kind of things, berries. And then fiber is a very kind of controversial thing because that can go both ways. Fiber can be very gas producing at times. It can also help you to go. It can make some people have the response where they'll have softer stool with fibrous foods, but then it also tends to add bulk to the stool. So sometimes we use it to kind of bind up the stool, but you need to really be cognizant about how much fiber you're taking. In terms of the exercise stimulates the colon to move. That's one of the things that we get that kind of wakes up the colon. Like I said before, I think eating, waking up in the morning, and exercise are the three things that we know really get the colon moving. And so certainly exercise has particularly if you're on the constipated side, exercise is fabulous to help getting things move.
Okay, great. Thank you. And we have like a gajillion more questions and probably not enough time, but let's see if we can do a couple more. So is it okay to have cramping after the enema has been infused?
Yeah, this is a sign that the colon's contracting, right? And so some degree of this absolutely will happen. It's not, yes, it's hurtful, it's not harmful. But that said, if it's very painful and you're having severe cramping and the cramping's going on long after the enema is over, then it indicates that probably the stimulant in that enema is too high. So whatever you're adding, whether it be like glycerin or bisacodyl or something like that, that's giving that kind of agitator, that stimulant to the colon, is probably too high a dose. But some degree of cramping is because that colon is contracting, and that's okay.
Okay, cool. There's a person who has been doing manual evacuation since they were 12. They are now 34.
Okay.
So the question is this method ideal or dangerous?
It is certainly not dangerous. And it depends on you if it's ideal or not, right? I have some people who do manual disimpaction, and for them it's perfect. They do it, they're clean, they're not worried about the accents. Other people really wouldn't find it ideal and would like to do something else. If you're getting out stool with this in a good fashion, so that you're getting enough stool out and you're not experiencing any impinging on the bladder of the stool, and you're not having any leaking in between, and it works for you, then I would say, yeah, it's ideal. And it's certainly not dangerous. The rectum's designed to stretch and to go back, so it's completely fine.
Okay, this one looks like it might be quick. Somebody's heard that lots of people are using more than water for the peristine and the cone enemas.
Yes.
Why would something be added?
So, we start with water, particularly warm water. You never want to put cold water into the colon because it can be a little shocking, and that can cause cramping. But if you're not getting out enough, if you're still having accidents, or if it's taking a long time to do, then we add something to add a little bit of a stimulation and to soften the stool. So we add things like Castile soap. Sometimes I'll add Miralax actually to the water of the peristine, or the cone enema. We'll add liquid glycerin. Sometimes we'll add things like bisacodyl. So there's many different additives that we can kind of ramp up and try depending on what the exact issue is.
Okay, thank you. And we're definitely past of our time, but this one seems like it might be a fast one, so I'm going to keep you just a second.
Sure.
The question is from someone who's 40 years old and has spina bifida, tried about every treatment except the ACE, and they're going to try the ACE. They think that they think it's the best option that they've heard of so far. But the question is, I should probably talk with my neurologist about this. Is that correct?
I'm not sure what, so are they worried because they have a shunt, and they're worried about, are they talking about like a neurosurgeon and they're worried about the abdominal surgery? That may be something. So I think it's important to get to talk to all your interdisciplinary team before you have a surgical procedure, particularly something that's elective that you can spend time talking to people. I mean, I know, in my practice, I work very closely with our urologists, and if they're considering doing, a catheterizable channel for urine, I'll often say, you know what, this is somebody who might be a good candidate for an appendicostomy, so that or a cecostomy for enemas. So why don't we combine the anesthesia? So sometimes I think it's good practice to talk to everybody, but that's the only thing that I can think of where they're going with that, is that they have a VP shunt, and that's certainly you want, and anytime you're going to have abdominal surgery, you want people to be familiar with what's been done. So I think having your providers communicate prior to anything is a good plan. Okay.
Thank you so much. Well, I think that, obviously there's a bunch of more questions. So I think this speaks to the need of having to revisit this subject. And so I've tried my best to capture all of the questions so that, we can be sure to address them either by email or maybe even having another webinar. So thank you very much to everybody who joined. Thank you so much to our presenters.
Thank you so much for allowing me to talk about this. This was great.
Yeah, thank you. And thank you so much, Amy and Adam. And do you have anything that you'd like to say before we part ways?
Yeah, this has always been a really difficult topic for me. It still is. And so I'm just really happy to have been a part of this. Hopefully it helps me. And I'm excited to look into these resources that you've given us, especially the guidelines. I think that's going to be a great resource for a lot of people.
Thank you so much, Amy.
Am I allowed to say where people can find me on social media?
Sure. You can go ahead and say that. And we've got your link here to your exercises as well.
Yeah. You guys can check out my exercise videos. That's my YouTube channel. I have an Instagram as well. You guys can message me there, SB_inspiration. And if you have any questions on this topic or anything else, feel free to message me.
Yeah, absolutely. And then actually maybe what I can do too is I can just, Adam, I can, in an email that goes out to everybody, I can share your contact information as well, or your Instagram as well.
Okay, sounds good.
All right. Okay, well, thanks again to everybody. Here are our email addresses for Judy and for myself, who did not introduce herself at the beginning. I'm Juanita. And yeah, thanks a lot, and we'll see you online at some point. Bye.
Thank you.
All right.
Bye.